nice to meet everyone today. The other bit of my job is I'm a professor of speech pathology at the University of Melbourne. I also work in 3 clinics as a speechy. 2 of them are ataxia, so one pediatric, one adult, and then I work in a frontotemporal dementia clinic here in Melbourne as well. So it's still seeing patients, but also trying to bring the research side together as well. Now, I was just talking about how blind I am before. I can't even see the writing on my slides, which I did last time as well, which was really clever of me. I'm going to get some glasses, I promise.
Do you need some help?
There is a way of making it so people like me can still read it. So just mentioned that I work with drug companies. They do give me money. They give other people money as well. And we help them make decisions about if their drugs are working. And that includes NPC. So you can see Azatharis are on there. We're working with them.
Is that right? No,
No, that's all right. I can see it. Yeah.
That bit. Yeah, if you hit the text.
And if we go, I can read that. That's good. Look at that. Awesome. So as a speech pathologist, I am trained to do speech, language, and swallowing, and they're obviously incredibly important in NPC. And today I'm just going to talk about what they actually are and how we measure them, and a couple of small little studies that we've run over the last few years in this space, and then the work that we're doing in the future. So speech is the motor manifestation, so it's how we sound. Language is the cognitive linguistic bit. So if we think about how we sound being speech motor and the language being the rules that govern what we say, things like grammar and syntax and morphology, we measure these 2 things, and then we've got hearing perception side of it, which is also very important in these populations. Another way of conceptualizing that is we have tasks that are very motor focused. So someone saying ah or pa 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 pa, which are part of pretty standard clinical batteries, all the way down to more complex tasks like a conversation or me trying to think of the words that I'm saying right now. That's not straightforward. If you have a brain disease, it becomes more challenging because you have to form a motor plan as well as the language plan that you're using. We use this protocol in a number of the batteries that we have. So thinking about NPC and our role, a species role, communication and swallowing, we're actually involved in multiple steps. Now here is something that I can't read, but if I turn around, I can read it. Difficulty coordinating movement. That impacts your ability to eat and talk. Abnormal eye movement. That also influences your ability to access alternative communication, but also even mealtime management, seeing what you're doing. Poor muscle tone, so hypertonia, that impacts both speech and swallowing. You're getting where I'm coming from here. A lot of the things that happen in NPC influence your ability to communicate and eat, and that has profound effects on your quality of life and your health. So I think my text is getting smaller by the slide, which is excellent. This first study I wanted to talk about was run by my colleagues up in Boston, looking at characterizing from a neuromechanism perspective what's going on when it comes to cognition and motor as well. And so the battery included a clinical presentation. They also did biomarkers, hand motor control. We managed to convince them that speech was slightly important in this population. You'd be surprised how many trials and studies run without the bits that, like talking and eating, kind of think they're important in our lives, but scientists don't tend to think so. Cognition, and then the big focus was actually on the brain imaging side and how we can link these behaviors to the underlying neuropathology within the group. There's lots of colors and squiggles here, but I guess there's just a couple of important things to take away. NPC demonstrated deficits in things that we already know. So there's things in this study that aren't especially remarkable, but speech production, timing and coordination and cognitive performance were all lower in the individuals with NPC. That's not the exciting bit. The exciting bit is how we then tied those behaviors to the underlying pathology. There's a couple of important aspects to the neural mechanisms that are driving deficits in Niemann-Pick, and they're related to motor speech functions. So if you have activation in insula or the supplementary motor cortex, these are bits in the motor strip there, and then with subcortical, they always light up when you've got a speech task when you're doing functional MRI. And we saw that they were involved in NPC as well. So what we're able to take away from this data is that the deficits that we're seeing, and this paper is published, so I'm not going to go through some of these slides, but in effect, we saw, Elizabeth just mentioned the 9-hole peg test, which is a task where you pick up a peg and you put it down in another bucket, and you pick up another one and you put it down. It seems like a pretty useless task to me, but people use it all the time still as a means of measuring limb and upper limb dexterity. That was impaired compared to healthy controls. And what we were trying to build was an argument around the cognitive deficits and the motor deficits and how they are manifesting in the brain of people with NPC. So 3 takeaway points from this particular study. Communication and cognitive deficits remain central to the NPC phenotype. So these are core domains of assessment that need to be pursued. And we saw, again, from Elizabeth's talk, they are 2 of the domains within the clinical assessment, whatever it's called, the NPC, CCSSS. There's a lot of repetitive letters in that one. The control of these deficits is central, which means it's in the brain, it's not necessarily peripheral. And that there's a clear link between the underlying brain pathology and these measures that we consider important for quality of life. So there's a link which we need to establish between how you perform from a speech perspective or a cognitive perspective or a motor perspective and what's happening in the brain for the disease. Now that's important if you go to someone like a group like the FDA, because they want to know, are you just measuring things that are happening within the life of the patient, or actually are they tied to the patient themselves because of the disease? Second study I wanted to highlight was one that we did with Mark Walterfang, not here, Dennis Velakoulis, not here, and a student of ours, Courtney Lewis, among others at the Royal Melbourne. We were looking at whether or not miglustat actually did anything for dysphagia. So we took retrospective video fluoroscopies, so the moving X-ray of a swallow, multiple versions of them over the years. So perhaps people will know some of the participants within this study, and looked at whether or not their presentation for dysphagia or swallowing problems changed over time. And what we saw was that 90% of people in the study, I say 90%, there's only 10 people in the study. 9 out of 10 people in the study had swallowing problems at baseline, and those deficits were manifesting as poor control of the tongue and a delay in the motor reflex for initiating the swallow. It's 2 seconds. I want it to repeat over and over and over again. Anyway, we'll go through that in a second. The delay in reflex for swallow is really common in any disorder that has cerebellar problems. So cerebellum's there to coordinate movement, and when it's not working as well as it should, there is a timing deficit that's presenting in patients. In my patients with Friedreich's ataxia or ataxia telangiectasia or spinocerebellar ataxia, all of them have a delay in their swallow reflex, and it also happens in Niemann-Pick. If you think about it practically, you put something in your mouth, you go to swallow it, but before you initiate that swallow, food or liquid falls off the back of the tongue before you're ready to swallow it, and then that has a cascading effect. And if we look at this image, which I wanted on a loop, but it's not going to go for it, we can see the liquid. This is a radioactive isotope called barium, so we can pick it up on an X-ray. We can see that it's actually going straight into the airway. So they're not initiating their swallow at all, which is problematic, or they are doing it right after they should. It's coming down here, and we can see trace elements of the liquid going down into the trachea. So liquid going down into the lungs is problematic. It's going to perhaps cause pneumonia, and we know that pneumonia is very problematic in NPC. The other point to make here is that there's no cough reflex. So This is not an NPC patient, by the way. This is illustrative, but in this case, the food or liquid is going down. There's no cough reflex, so there's no clearance. So they're silently aspirating, which is even more problematic because you can go an entire meal and have everything go the wrong way rather than actually just swallow it safely. I'm happy when, well, not happy, but I'm relieved when people cough during a swallowing exam because that means they're clearing it. If they're not, and we think that there's something wrong, then that's problematic. The last slide I've got is as a Pharos. So they spoke yesterday, although I just heard that they've got incredibly strict inclusion criteria, which I think is going to cause some problems from a recruitment globally, but we'll go through that at another time. But I'm very pleased because this particular company are including an objective, as far as video fluoroscopy can be objective, measure of swallowing in their protocol. So a secondary outcome. It's quite rare for a drug company to include very challenging assessments like this because they are funded by people who want money, and the money only comes if it's easy to measure a drug, if it works. As a Pharos have bitten quite a big issue here, and I'm hoping they can make some hay. This study is only in kids, but they're measuring using that video fluoroscopic technique performance in their trial. So good luck to them if they recruit any patients anywhere. Thank you for your time.
Thank you so much. Does anyone have any questions for Adam? Yes, Ellie.
Great talk. Two questions, and they might be linked. One, this might be an obvious question, but I'm not too sure if I missed it. Swallowing and speech, would you find that they are obviously very connected, but they are different mechanisms, as you were saying? Somebody who struggles to swallow, would you also find that they have issues with speech or the other way around? That was one question. And the second one was, if you do find that food, they're silently aspirating, so food is going into the lungs, how is that actually cleared by the body? I know pneumonia is something that can happen out of that, but if it's not pneumonia, is there a way for the body that naturally clears what's in the lungs?
Yeah. So the first question is a common one that I get, and they are different neural mechanisms, although there are overlapping areas of control. So they're both motor manifestations. They are both in the same laryngeal oral space, but they're controlled by different parts of the brain. You can get people who have a dysarthria or a speech problem and no dysphagia, and the other way around as well. So it'd be nice if we could just measure dysphagia with speech. I think that'd be a lovely way because it's quite an easy way to do things, but it doesn't link up. Second one, if food does go down into the lungs, the body can clear it in some way. I mean, it can just dissipate into the rest of the lungs and then kind of slowly work its way out, or it can turn into an infection. It's also not a one-for-one. If food goes down into your lungs, you don't necessarily develop pneumonia. It depends on your immune system and a few other factors. So it's not a direct relationship, which I'm always pleased about because there are people who in my clinics choose not to modify their diet or do anything about their swallowing problems, and they prefer to just eat whatever they want. And I certainly advocate for that. I'd rather just continue to have a non-modified diet, but they may have things go wrong, but it doesn't necessarily mean they're going to get sick from it.
Sorry, it might be an odd question, but I guess just thinking outside the box a bit. If you do have patients that are silently aspirating, is this because they aren't like the reflex of coughing isn't initiated, or can they not cough? And in saying that, if they can still physically cough, would it maybe have some therapeutic benefit of having patients who are known to have swallowing issues, like get them to cough after meals or liquids?
Yeah. So we'll start with the last one. Yes, you can get people to clear physically rather than having it automatically done. So you can say, please clear after every mouthful. You can also have increased oral hygiene by making sure that they flush out anything that's there. You can get them to have a drink perhaps. I mean, having a clear liquid go into your lungs is not really problematic, so you can have that done. It's often a sensory issue, so not picking up the fact that something is going the wrong way and the timing. I feel like there was a third component to what but none of it was odd and none of it was out of whack. It was all sensible. Thanks, everyone.